So the next step up probably would be Vicodin, which is hydrocodone. Vicodin is probably one of the most used, most prescribed medications in the United States. Hydrocodone, and usually Vicodin, hydrocodone usually is combined with Tylenol to form Vicodin. You rarely write for hydrocodone by itself. So make sure you're aware of that, because sometimes people will combine pain meds containing Tylenol with Tylenol by itself, so that can cause problems. And Vicodin and the next step up, Percocet, can be drugs of, or these all can be drugs of abuse, but these are fairly common drugs of abuse. Percocet is Oxycodone. Oxycodone is more powerful than hydrocodone. And Oxycodone does come by itself as well, but most of the times we use it as Percocet. Both these can cause kind of euphoria and confusion, so you have to be careful using it with especially elder patients and also young patients who like to abuse it. It's really important, if you're starting these medications, to do various screens for possible drug abuse or diversion. More and more we're being regulated on how we write for them. And so we try as best as we can to limit it, but it can be challenging, to be honest with you. Usually these are kind of shorter acting medications. They usually work about 6 hours or so. And so there are some cases where where someone has chronic pain and they have chronic pain all the time. And those are the cases we need to use long-term medications. So there's two commonly used long-term medications, and they can be identified because they have the words contin in it. So there's Contin, and there's Oxycontin, and they're both long-acting, like 12 hours medications that you're supposed to take chronically. Contin is morphine, so it's extended-release morphine. And Oxycontin is Oxycodone extended release. And the idea behind this is they would provide kind of a basal level of pain relief, and so that you would still be able to use short-acting medications, but this would provide kind of relief of the pain. While if they were going to go for a run, they might take a short-acting Percocet to kind of cover their pain during that time period. And so there's also, I try to use Contin preferentially because it's a lot cheaper and it has a lot less street value, which helps to decrease the chance of diversion, although it's always possible. Morphine, I didn't talk about it, but morphine is a medicine more commonly used on inpatients because it's more typically an IV pain medication. So you'll probably use it a lot when you're on inpatient service. Another medicine that we use for long-term pain relief is called Methadone. Now, you might have heard of Methadone in context of heroin rehab. We commonly use it for that purpose. It's a long-acting, very powerful, difficult to titrate medication. It's also very cheap, so sometimes I do use it. We use it a decent amount in hospice patients as well. So one thing to be aware of with Methadone is it can cause QT prolongation, which can cause arrhythmias. So especially in older patients, if you're going to start someone on Methadone, you want to check the EKG beforehand. But to be honest, I don't really use it too much in older patients. Because it's such a slow onset medication, you have to be careful with Methadone because sometimes people don't feel like it's working, and it actually is. So they take more of it, and it can all accumulate and cause someone to pass out, which is bad. Next up, in terms of potency, there's an as-needed medication called Dilaudid, which is hydromorphone. And a lot of times you'll hear medical people joking about patients wanting Dilaudid because they have quote-unquote morphine allergies. Yeah, I rarely use it, but it is very powerful, and it is an option for people, especially cancer patients or people who just have bad reactions to other medications. In cancer patients as well, there's a medicine called fentanyl, which comes in a patch, fentanyl patch. And this is very potent, and it's not really abused as much because you can't get really high on it. Well, I guess you can, but there's no rush like you would with other kind of short-acting medications. This is oftentimes used in hospice care, but you have to be very careful because if you apply it wrong or put some kind of heat on it, then it can release more of it than it's supposed to, and that can cause you to overdose and stop breathing. A lot of people die each year from fentanyl overdose. And so really you want to be careful using really strong opiates.